last block, second year of M2, and you know the theme is regulation integration. One of the major organ which is dealing with this system is kidney, and kidney is very important in many aspects. Not only it is taking care of all the excessive wastes physiologically, and also temperature regulation, RBC productions, erythropoietin production, and a lot of other ways. It is very important for our body, and that's why when a failure of kidney occurs, we are commonly seeing that the patient responds with edema, with a lot of swelling of the body. Why? Because the proteins are lost. So in first semester we learned, or even in the first block of this year, that one of the common reasons for edema to develop, there are four main things: increasing in hydrostatic pressure, decrease oncotic pressure. So in this specific pathology, the decrease oncotic pressure, because a lot of proteins are lost in the body, so that is one reason that our body develops edema. Obviously, there is some hydrostatic pressure which develops and proteins, but mainly decrease in oncotic pressure. And when a kidney got failed, when kidney got pathologies or diseases, then the normal physiology is disturbed. You already know physiologically that the kidneys are in reserve of more than, like one kidney is taken completely, a body can function normally. The kidney function was not disturbed. The rest half is also taken, even then the kidney will be working. It is having such a reserve. But once that is also disturbed, then the effect can be seen. And how the effect can be seen? What are the tests which will help us to see that the kidney is going to fail? Yeah, for example, by which investigations you would have some idea?
Protein level.
Protein level, obviously.
Glucose level.
Yes, the protein or glucose level obviously will be affected, but they can be seen in other diseases. But there is one or two specific tests which are typically for kidney diseases or kidney. Yes, glomerular filtrate level. You check by which mechanism? By
GFR.
GFR is measured by which investigation?
By injecting a dye in the system, this dye will be completely filtrated from the body, and it has a specific timing for it. If it increase or decrease, we have to check.
Yeah. See, this is something which we call urography. Okay, that is to see the anatomy, to see the disturbed anatomy of the kidney. But it also helps about the functioning, obviously. But the best biochemical testing, which can, without doing any investigation, just you check the blood serum and you find if the creatinine level are increased, because GFR is measured in creatinine clearance. Okay? So if the creatinine clearance or creatinine level are higher than 2.0, then this is a very alarming sign that the kidney are failed. The other thing is urea. Obviously, if the urea is markedly raised more than 50 gram per deciliter, it is also one of the very important features, but it can be raised in cases of dehydration by other things, but it can give you a hint. And obviously you can go for urography, and you can go for glucose levels. There could be anemias and other things which can happen. So now we start and open blocks. So this is a common clinical scenario. A young boy, which when he gets up early in the morning, there is typical periorbital swelling. Okay. Similarly, a lady which is having pedal edema. In skills, they have tell you about the pitting and non-pitting. So you can see that when the socks, which is called jurab,
yes,
when they are removed, when they are taken out, you can still see the markings of these. So there is a lot of pitting which is still present. So these are the common clinical scenarios which can be associated with the kidney failure, with the kidney damage in cases of liver.
Only in the early morning, so after that
it can happen, but it will start, it will decrease after.
Yes.
Why it is early morning?
After sleep?
Yeah, after sleep.
Because he was lying.
Yeah, so it's there is some role of gravity also. And
Question.
Intraocular pressure, yes. Actually, these are very soft areas, soft tissue. So once there is edema and a person is lying for a long time, so a dependent edema develops here, and when he gets up, it's very common. Even those who don't have renal failure, still we get up in the morning and there is typical
Puffy
swelling,
eyes.
puffy eyes. And with passage of time, this solves, and after you wash, after you make wudu and other things, the swelling goes off. But this minor amount of edema or swelling is okay. There is no problem. But once there is so much severe, you can see the boy cannot open the eyes. It's very significant. So we will see in which particular disease this can be seen. So we will start with some glomerular diseases, because the kidney pathology should be discussed starting from glomeruli, then the tubules, then we can go for some other inflammatory disorders, then we can go for some tumors which can hamper the kidney function. The glomerulus, I think this diagram histologically maybe you are familiar with. If you are not, then I can go in detail. If
Yes,
you're-
go please.
Go.
Remind.
Okay. So what is in the center of this glomerulus? They have cutted this glomerulus at this level.
Mhm.
You can see this is the cut section. What is in the center here?
Mesangial cells.
Mesangial cells. What is the function? Support of
The glomeruli.
the glomeruli. Okay. Then you already know that, suppose this is it, and the glomerulus are the tufts of capillaries. This is the proximal, this is the distal. So here, this one, there are two types of, what is this thing?
The epithelium.
Which
Parietal.
there are two types. You know what is the Bowman's capsule?
Yes.
Okay, so this is the Bowman's capsule.
Yes.
What is the Bowman's space?
Between the glomerulus and the capsule itself.
Yeah. Any other good way? What is the Bowman's space? It is actually, if you can see, that there is two types of epithelium here. One is the visceral. Okay, you can see here. It's also mentioning. This one is the parietal, and the one which is just adjacent to the capillaries.
Mhm.
That is visceral.
Okay.
So visceral, which is attached to the viscera, and the parietal, which is just attached to this end.
Capsule, yes.
So the space in between the visceral and parietal epithelium is Bowman's space.
Mhm.
Actually, the capillaries are in the center, the glomeruli. Whenever there is some filtration, you can see the RBCs which are running through this. There is a big RBC, and these are the fenestrations, the small gaps in the capillaries, from where the filtration happens. Then there is a basement membrane, glomerular basement membrane of the capillaries, endothelium. Then the fluid has to pass through these filtration slits or podocytes. The foot processes of the visceral epithelium is called podocytes.
Podocytes.
It is called
Podocytes.
podocytes. So these are all podocytes. And from these gaps, actually the filtrate is coming into this space, which is called Bowman's space. And this Bowman's space is then connected with the proximal collateral tubule and then loop of Henle and so on. So this structure should be in your mind. This is very important to know glomerular diseases. This is just a concept. The normal glomerulus is like that. It will not allow the bigger molecule and the charged molecule, especially the positive, especially the negative one, to cross this filtration. Okay? So the larger molecules and the negatively charged molecules will not be able to cross this filtration slit or this filtration membrane, and they will be rejected. So they will go back, and that's why the proteins which are larger in size, they should never be seen in a normal person's urine. Okay? You got the point?
Like albumin.
Like albumin. Globulin, which is even larger. So they should never be seen in a normal person's urine because of if the glomerulus is normal. However, whenever the glomerulus is damaged, either there could be logically two things. Either the glomerular filtration slit has become larger, bigger because of damage, because of anything, which I will tell you shortly, or the charge on this membrane has been lost. So previously this charge which was negative on the membrane was causing the repulsion of the negative charged particles. That charge is lost, and you can see even these electrolytes, they are coming out of this membrane and they are coming into the open space. How this can happen, we'll see. So we are actually starting here that there is one of the from here you can see there, whenever the filtration channels are bigger, it is causing the proteins to lost, which is leading to proteinuria. Actually this diagram I will show you a little bit because I want to ask you a question, then I will come back to this diagram. So how the glomerule can be damaged? So you know there should be bigger gaps and the charge on the membrane should be lost. But how it could be lost? Then there are some mechanisms. We know from this histology that the glomerular basement membrane is already there. Then we know that the podocytes are there. Okay, if you keep in mind the basement membrane, the capillary endothelium, then the podocytes. So these are the three main structures which are there. So for the membrane to be damaged, there should be something which is damaging them. Either that is damaging the glomerular basement membrane,
Yes.
or it is damaging there are some complexes or there are some antibodies against the podocytes or against the glomerular basement membrane, or some even to the capillary endothelium. If there is so much inflammation, then it can damage the capillary itself. Okay. So what these things can be? Number one, the most common thing is that there are usually, remember one thing, that glomerular injury is usually immunological. It is because of either antibodies or antigen-antibody complexes. Those complexes and those antibodies are either formed at the site of the glomerulus,
Yes.
or they are formed somewhere else in the body, and then they came here, and then they stuck here. And when they stuck here, they activate the complement activation system. Okay, so the complement system after gut activation start to damage the capillaries and the glomerular basement. Okay, so it could be many things. Number one, antibodies against the inheriting glomerular basement membrane. So antibodies, they were formed and they stuck in the glomerulus. They attacked here.
Yes.
Then the antibodies against the planted antigens, some antigens like for the mesangial cells, for the capillaries. So there are antibodies which are for the antigens which were stuck here, and the antibodies came to tackle them. But instead of tackling them, they start also to damage the glomerular basement membrane. Then already the antigen-antibody complexes were formed. For example, you have wrongly given a person's, positive person with a negative blood, or vice versa, and there is already formed some complexes, hypersensitivity reactions.
Yes.
So because of those hypersensitivity reactions, some complexes have already been formed in the blood, and those complexes, they are traveling everywhere in our blood, in our circulatory system, and they start to gather into the glomerular basement membrane. Why? Because this is the common area where it should happen, and there they start to damage the glomerular basement. Okay, so there could be already formed complexes which trap into the glomerular. That's why they are damaging the glomerular basement membrane and other areas. Then there could be antibodies against the glomerular cells. For example, against mesangial cells, against podocytes. As we discussed, these are the normal structure. There could be some antibodies directly against them. Or sometimes there could be cell-mediated immunity. There are some sensitized T cells. So all previously were either antibodies or some complexes. And here there are T cells, cell-mediated immunity, which are sensitized already. For example, in cases of tuberculosis, in cases of SLE, in cases of some other autoimmune diseases. So they are already activated, and they also came to the capillary endothelium here, and they start to damage the glomerulus itself. So these are the different mechanisms by which ultimately the pores were damaged, the filtration membrane was damaged, leading to leakage of the proteins and other electrolytes. Okay.
Excuse me. First one, the antibodies against the inherited glomerular. Does this mean this is an autoimmune disease?
We can say autoimmune disease. We can say in that sense. Why? Because the glomerular membrane are already there, so they directly came to attack them. Okay? And these antibodies, but these antibodies can be injected. These antibodies, if they are formed within the cell, then it is not.
So one of the possibilities.
One of the possibilities.
The second one for the planted antigens, meaning, for example, if he got virus or bacteria in the kidney.
In the kidney.
So
And
these
the
are
body-
planted, and then the antibodies come attack.
Attack them, and while attacking, they also damage our capillary endothelial cells.
Thank you.
So rest of all is. So this is the same diagram which is telling that either there are circulating immune complexes, already formed some complexes there in the blood, and then they entrap into this membrane, and that's why they start to damage either the capillary or the basement membrane or the podocytes, or there could be in place in situ complexes or in situ antibodies, for example antibodies against the basement membrane. So you can see that all antibodies, they are typically at the level of glomerular basement membrane. Or sometimes there is antibody against the glomerular antigen, which is, for example, in membranous nephropathy. So you can see that there are some antigens which are already into the podocytes, and the antibodies are coming via blood to attack them. So this is an example of planted, in which they were planted and they are coming to damage them. Yes.
First one.
Yes. Yes, these are already formed antigen antibody complexes. For example, erythroblastosis fetalis, any antigen antibody complexes which is already formed in the circulatory system. And it is also, because it is also part of our circulatory system, and it also came there. Once it came there, it's stuck in between the podocytes and in this level, it cannot go. But once antigen antibody complex is there, they always activate the complement system. They always activate the inflammatory system. So that inflammatory system or complement system is damaging our filtration membrane. After they are, whatever is the reason, antibodies or complexes, whatever, they start to activate a lot of inflammatory mediators. If you can recall the inflammation, so it could be neutrophils, monocytes, macrophages, T cells, NK cells. What are NK cells?
Natural
Natural cells. It could be platelets, mesangial cells. So any one of them, ultimately the antibody deposition, or if there is T cell response, they will go through activation of complement system and can release or damage the epithelium, endothelium, mesangial by oxidants, or what are the oxidants?
Okay. Oxygen reactive species.
Yes, also called as free radicals.
Yes.
So oxygen, either the free
H2O.
radicals or cytokines like tumor necrosis factor, interleukin 1, interleukin 6, proteases, growth factors, any one of these are ultimately which are released from these products, they can damage or they can help in the damage of this basement membrane, leading to glomerular injury, and these glomerular injury will end up into glomerulonephritis. So the conclusion of all these glomerular injuries is that the antibody deposition or the circulatory antigen antibody complexes, already they were formed somewhere else against any antibody or against any antigen, and afterward they came here. This is the normal one and this is the abnormal, in which these podocytes are damaged, they are flattened, the basement membrane is damaged, and the filtration slit is bigger, and the proteins or solutes and everything is coming via, because this membrane is not damaged. So the conclusion is that the antibody deposition or circulatory antigen antibody complexes trapping in the glomerulus are the major pathway of glomerular injury, which can result in glomerulonephritis. Okay, till now is it clear?
Yes.
So now, based on this knowledge that how the glomerular can be damaged, we will come to discuss some specific diseases which can end up into some syndromes. So one of the very common syndrome which can result into, or clinically these syndromes are very important. Whenever you go to clinics, they will discuss cases based on these syndromes. So you should know that what are these syndromes. So one of them is nephrotic syndrome, and other one is nephritic syndrome. Okay. So I have already highlighted the word which is the main word which will help you to differentiate. I wrote here nephrotic and make O bigger. Why? So you can remember that the protein also have an O and nephrotic also have O. So it means this is something which is major related with proteinuria. It is related with proteinuria, and that proteinuria is more than 3.5 grams per day. More than 3.5 grams per day. It means the proteinuria is such extensive that if you calculate the whole day and calculate the proteins, it should be more than 3.5 grams per day. You can also remember the nephrotic features of nephrotic diseases by this mnemonic. So I have this mnemonic. It tells us protein leak. You know, actually, you know, the leaking means the actual spelling of leak is L-E-A-K. Leak.
Yes.
So why? Because in nephrotic, actually, the proteins leak out. But just to fit in with this, so we change K with C. But you will know, you will remember the features of nephrotic by this mnemonic. What are these features? So the protein will tell that there is protein urea, and L will tell that there is lipid up. It means there is hyperlipidemia. It is hyperlipidemia. E means there are two actually, lipid up, hyperlipidemia, and there is lipid urea. There is a question here. You know, where there was a lot of protein urea, it means the protein were lost with urine. Ultimately, there was decreased protein in the body. It means hypoproteinemia or hypoalbuminemia.
Yes.
Okay.
But why?
Why? Because there is a loss.
Albumin loss.
Albumin is lost. The production is normal, but the loss is there. So this will result in decreased amount of albumin or proteins left in the body. Is it logical or not?
Yes.
But lipid.
Doctor,
Lipid.
you asked us this question last year.
Last year.
Yes. The answer is that the LDL and the No, you asked last year.
Yes, I will ask again. So you remember with protein urea, ultimately there was hypoproteinemia.
Yes.
This is recognizable. This is understandable. But there is hyperlipidemia. Still there is lipid urea. There is lipid urea, but not hypolipidemia, but hyperlipidemia. So this is the question.
Because lipid is a lot.
You know, with excessive protein urea, there was hypoproteinemia. The albumin got decreased.
Lipid shouldn't be in the urine.
Yes.
The lipid shouldn't be in the urine. So when you see it in the urine,
Maybe because the
lipid
blood,
urea.
the blood will increase the HDL, but the human LDL.
This is actually what happens that whenever we are losing proteins, losing proteins, and our liver is trying to compensate that albumin by producing more albumin, and albumin is carried in combination with lipoproteins. So once these lipids are, these proteins are made, the lipoproteins are made, so that they can carry them from one place to other place. So in result, but this lipid, which is this albumin which is made, it is again lost. But the fat molecules that is having typically what is called the
Intrahepatic circulation.
Intrahepatic circulation. It is going away all the time. It is not lost. Initially, you can see the lipid urea is there. The cholesterols are coming in the urine. You can also see that the cholesterol level in the body increase. Why? The reason this will increase, but still the more albumin is produced to compensate for the hypoproteinemia, the more lipoproteins increase in the body. So that's why, as a compensatory increase as compared to the albumin, we will find hyperlipidemia in the body. So if you can go through this slide, there you can see it now. So this is protein urea. So there is hypoproteinemia, and whenever there is protein urea, the lipoprotein lipase deficiency will happen. It is something controversial. So hypoproteinemia will cause more protein to form with the lipoprotein synthesis, because they are not made alone, rather they are in combination, they are coming. So there is excessive lipoprotein synthesis which will cause hyperlipidemia. But these proteins which is made, they will be again lost through the kidneys. But these lipids which are made, in the intrahepatic circulation, it is going on and gone. So this will cause ultimately increase in the lipids in the body, which is resulting into hyperlipidemia or hypercholesterolemia. That can happen. So the edema is because of usually decrease oncotic pressure. You already know one of the reasons why there is edema. That is because of this decrease oncotic pressure. And ultimately, whenever there is a decrease oncotic pressure, there is hypovolemia. So ADH system is activated. It will cause more aldosterone, ultimately more angiotensin 1, angiotensin 2, and the whole process through physiology you already know that it will be activated. Okay, so who will tell me the points of nephrotic? Number one,
proteinuria,
3.5
lipidemia,
hyperlipidemia,
lipiduria,
lipiduria,
edema,
cholesterol up,
edema.
edemas. Okay.
There's A.
A for albumin,
Ah,
albumin down, or you can see that
yes, albumin down.
albumin
yes.
down or
Hypoalbuminemia.
hypoalbuminemia. Okay, so these are the features of nephrotic syndrome. But if you can forget other things, you should never forget these two things: proteinuria and hypoalbuminemia.
Yes.
This is the major thing for nephrotic syndrome. Now we come to nephritic, and you know the word itis means
Inflammation.
inflammation. So that's why in nephritic there is mainly hematuria, and you know hematuria is always whenever there is excessive
Blood.
damage via inflammation. So in these glomerular diseases there is actually inflammation which is going on, which is causing excessive gross hematuria. The word gross means it is showing hematuria which can be seen with the
On a
naked
large
eye
scale.
also. With the in the large scales, which you can see even with the naked eyes. Okay.
Yes.
There is another type of hematuria which is called microscopic, which you cannot see while you see the urine, but once you go for chemical analysis, or then you can find or urine analysis, then you can find that there is more. So there is in nephritic, the major feature is itis or inflammation, which is causing hematuria.
Yes.
Okay, so you can remember itis is inflammation which is causing hematuria. Obviously, there is proteinuria, but it is less than this. There should be, because the glomerulus is damaged. Even if it is inflammation, the result is that the glomeruli are being damaged. So when they are damaged, there is some protein loss. There is some protein loss. So it is not that there is no proteinuria. However, this proteinuria is mild up to moderate. Then there is azotemia. Can you tell me what is azotemia? Yes. Last time in R1 we discussed about this. Again, what is azotemia?
I forgot.
Okay, so azotemia is elevation of blood urea nitrogen and urea. Okay, so these are the biochemical tests which or levels which are increased whenever there is azotemia. Increased level of blood urea nitrogen and creatinine or urea. So these burn, and the creatinine level when they are raised, this is called azotemia. And what is uremia?
Results of nitrogen. Excessive
More uric acid in the blood.
That is hyperuricemia. No? Uricemia. Why we are talking uremia?
It's urine.
Urea.
excessive
Urea
nitrogen
in
in
the
blood.
blood.
Excessive nitrogen in blood.
But that is azotemia. What's the difference between azotemia and uremia? And uremia is
Can I say this? More of the wastes that are in the urine should accumulate in the blood.
no. The difference between uremia and azotemia, actually both are similar. Both have elevated level of nitrogen and urea and creatinine. The only difference when we have the clinical signs and symptoms of or clinical manifestation of uremia or urea increase, then we call it as uremia. And if we don't find the signs symptoms, like we don't find edema, we don't find hematuria, we don't find other findings of these nephrotic and nephritic, but still when we check the level of nitrogen is raised, but still there is no manifestation in the body, then we say it is azotemia. It is just biochemical test which is telling that this is increased. But once you see the sign symptoms of this disease in the body, then we call the same as uremia. So the only difference is the clinical manifestation. Okay? It is the same as septicemia and bacteremia. Septicemia and bacteremia. Bacteremia is also blood in the blood,
Bacteria
in the blood, and septicemia is also bacteria in the blood. The only difference, where it is symptoms, system complexes, it is called septicemia. And when there is no symptom, but still, by the way, you check the blood and why? Oh, there is increased Staph aureus in your blood. There is increased this. So that is something the biochemical test, but
What
not the.
happens in uremia?
Yes.
What happens exactly in uremia?
Yes, in uremia there is typically the breathing will be more because of increased solutes, electrolytes, they will be retained in the body. There will be typical edema, there will be hypoalbuminemia. So all these manifestations which we are going through, they are usually seen in uremia also. There is typical acidotic breathing. A person will be breathing more because this excessive nitrogen, he had to take it out. So there is a whole disturbance. In physiology, you just go through this topic. If you can review, you will find what could happen there. So there is azotemia, edema can also be there and here. There is typically hypertension here. And the most common disease which can present with nephritic is acute post-streptococcal glomerulonephritis. Acute post-streptococcal glomerulonephritis. So what are the features of nephritic?
Acute post-streptococcal glomerulonephritis.
First go to the, whenever something is being asked, always remember to quote the first thing first.
Inflammation.
What's it?
Hematuria.
No, proteinuria is the secondary thing. in
Hematuria.
nephritis.
Hematuria.
of the
Inflammation. So you should remember nephritic is inflammation leading to hematuria.
Yes.
So first always tell this. If you write all the points and you don't mention hematuria, you will lose grades, even half the grades. Okay. So always try to see what is the most important points, 2 or 3 maximum, and then you should mention them. Maybe I will give you give three differences between these two. So you will, if you will give others but you don't give these and these, you will lose more than half of the grades. Okay. So there is this, then mild to moderate proteinuria, azotemia, edema, hypertension, and
Acute post-streptococcal.
this is one of the diseases. What are the diseases which can present with nephrotic, and what are the diseases which can present you with nephritic? So it is very easy to remember nephritic by the mnemonic word Paris. So you all know about Paris. Some of you have already traveled. So P, so you can remember post-infectious. It means this is the disease which happens in some infections, very commonly again because of post-streptococcal. We will go into detail shortly, but in the next lecture. This we will discuss today. A for Alport syndrome, which is an example of hereditary nephritis. R for rapidly progressive glomerulonephritis, also called dysenteric glomerulonephritis. I for IgA nephropathy, and S for SLE. Well, SLE can be both here and here, but it is usually presenting with nephritic. So what are the diseases with nephritic?
Paris. Post-streptococcal.
Yes.
Post-infectious.
Alport syndrome.
SLE.
R for
IgA antigen.
rapidly progressive glomerulonephritis. Then I for
IgA
nephropathy. And when I will ask in exam, you will say Paris. You know, but Paris is just to let you remember. It is not in your book, huh? It is just to remember. You write Paris and you think that I know all of them. No, you have to tell them. So as far as now, what are the diseases with nephrotic? So there are 5 main diseases. Number 1, there are 2 diseases with M. Number 1, minimal change disease. There are rather 3 diseases with M. Minimal change, membranous, and membranoproliferative. Okay, what are the 3 diseases starting with M for nephrotic?
Minimal change,
membranous, membranoproliferative. Then there is one disease with F, focal and segmental glomerulosclerosis, and then the systemic disease. Okay, so it's easy to remember. What are the diseases with nephrotic?
Minimal change.
Minimal change, 3M,
Membranous.
FS. Okay.
Membranoproliferative.
Membranoproliferative,
Yes.
focal and segmental, and then
Systemic
systemic diseases like diabetes, like rheumatoid arthritis, nephritis, all these, or amyloidosis, drugs and
The
infections.
GN means
Glomerulonephritis, yes. GN would be a word which we use commonly here, which means glomerulonephritis. So now we start some of the nephrotic diseases. Number 1 thing is the minimal change glomerulonephritis. So minimal change is an example of nephritic or nephrotic? It is related with nephrotic, not nephritic. Okay. So first thing, if you know which group it is, you can easily write that there is excessive proteinuria. So you can find there is massive proteinuria, meaning minimal change. It is the most common cause of nephrotic syndrome in children. So if a children is diagnosed or is having features of nephrotic syndrome, then they start treatment even without biopsy. Why? Because this is the most common thing which happens. What is the treatment? They give steroid therapy. 90% of the children with steroid therapy, they respond and they become okay. And that's why it is also called steroid sensitive glomerulonephritis, SSTN, steroid sensitive nephrotic syndrome. Okay? So there is a massive proteinuria. There is urinary loss of albumin, but remember this proteinuria is selective. What is the difference between words selective and non-selective?
Selective, the list going out.
Specific types of
Selective.
proteins are lost. But
Yes.
not specific all.
Yes,
or
if there are all, it will be non-selective.
Yes.
If there is only few,
Limit.
for example, albumin in this case, so it is just selective for albumin. While the other proteins, what are the other proteins?
globulin.
Globulin, there could be other plasma proteins.
Yes.
They can also be lost in cases of, if there is non-selective. But in this case, this proteinuria is selective, which is giving or allowing only albumin to come in the urine, but the larger protein molecules like globulin and others, they will not be seen in the urine. Okay, so that is one of the differentiating clinical concepts. So what is morphology? How you look, what you see in microscope, in gross. So glomeruli are normal by light microscope. When we see them by simple electron microscope, normal microscope, compound microscope, actually we don't find sometimes any changes in the glomeruli. They can be fairly normal. But how then, what is the pathology? Then we have to go for electron microscope, EM. So the word EM will be electron microscope, L for light microscope. With electron microscope, we typically see that the food processes, they are getting effaced. They are getting bigger. As you see here, this one, this is called effacement. When they are this one, this is normal. When they got a little, in the
Stretched,
more
like
stretched,
stretched, yes.
When they become more flat, this is called effacement. This is called effacement. So we typically see that the food processes, this is the normal one, they are getting effaced, they are getting dilated. So it depends on severity. The more severe minimal changes, the more effaced they will be. So this is the only finding which we can see in cases of minimal change disease. Again here, you can see that the food processes are totally effaced. They are just like this, not the regular spikes.
Yes.
The second one, what is the second one in nephrotic?
Focal.
Focal segmental. Any other with M?
Membranous and
Then
membranoproliferative.
membranoproliferative.
Systemic.
Then the systemic, for example, diabetes and SLE and others. So the second one is focal segmental. This is the most common cause of adult nephrotic syndrome.
Okay.
So if an adult is diagnosed with nephrotic, they will think first about FSGS. And if a child is having nephrotics, it means massive proteinuria, they will
Minimal
think
change.
about minimal
First
change.
one.
So most common cause of adult nephrotic syndrome, it is a clinical pathological diagnosis. And what is required in this diagnosis? Number one, having proteinuria or nephrotic syndrome, which is obviously that nephrotic syndrome means having proteinuria more than 3.5 grams per day. Number two, there will be focal and segmental sclerosing lesion on light microscope. I will just explain what that means. Absence of immune deposits on immunofluorescence. So they will go, there is another test. In the same biopsy, they use a microscope which is called immunofluorescent microscope. So there will be no changes or immune deposits in cases of immunofluorescence. And the fourth thing is there is evidence of podocyte injury on electron microscope. So when we use electron microscope, we typically see that the podocytes are damaged. They are, injured at some places. So when these are there, we call this as FSGS. Clinical features, it occurs at any age. There is proteinuria, but that is unselective. What that means? Everything. It could be including globulins, other plasma proteins, albumin, etc. Most patients develop renal failure. So this is one of the differentiating feature. And it is usually associated with people who have HIV, means AIDS, who have addict to heroin. So a lot of people who are using drugs, especially recreational drugs, they are usually having glomerular injury and presenting with FSGS. So heroin and other recreational drugs, sickle cell anemias, usually they can have damage to the glomeruli with FSGS pattern, and even sometimes they can be associated with
Like these are the risk factors.
yes, these are the risk factors which can end up into FSGS.
Can also, for example, if someone has increased uric acid.
Uh,
Affected?
yes, uric acid, definitely hyperuricemia is one of the reasons which can damage, but usually it will not come into directly FSGS. Increased level of uric acid will damage glomeruli, but more the tubules. The tubules and the interstitium will be markedly damaged.
Okay, if someone he has elevated uric acid, but he
Yeah.
drinks a lot of water,
Yes.
can it protect?
It will protect definitely, because excessive water intake will cause the flushing will become normal and the damage to the glomeruli will be continued. So morphologically, diet microscope shows just like its name. What is its name? Focal
Focal
segmental glomeruloscopy. What is the meaning of focal?
Focus.
Suppose there are, we see a biopsy and we find 6 glomeruli.
Can you please turn on the light?
Where is? So there are 6 glomeruli. Out of these glomeruli, we find not all of them. If all of them are involved, this is called
Global.
Global. But this is focal. It means
In a focus, one area. Focus
this
on
one,
one area.
this one, these are involved. Rest are normal.
Yes.
So this will be called focal. What is the meaning of segmental?
Segments.
Segments. A small part of glomeruli. So even those who are involved, they don't show that whole is involved. Rather, there is only part of the glomeruli which is involved, like this one, like this one. But the rest of the glomeruli is even those which are involved, they are not involved. So this thing is called focal and segmental glomeruli. So on light microscope, we will find focal segmental pathology. What is focal? Involving some glomeruli, and segmental means involving part of the glomerulus, as you see here. Okay? So that's why this disease is named as focal segmental, and the word sclerosis means hardening. So here you see one glomeruli, and actually this the blue stain here is telling us excessive fibrosis and damaging or sclerosis which is happening. So you can see half of the glomerulus is showing it markedly, and rest is not involved. And if we see all of them in this case, so all of them will not be involved, rather some of them will be involved. So there is hardening or fibrosis of the part of the glomeruli, and some are involved and other will not be
So,
involved.
can I please ask a question? If you said only part, so
Yeah.
only focal and only segmental, why would it lead eventually to renal failure?
Yes, actually even then the damage is so extensive that because of some associated factors and because of this, that this will show results in a very late time. It means already there is a damage which is going on, and there are so much damage ultimately, even if it is focal, that the normal kidney ability to have
Shut down.
Yeah, to maintain its body, homeostasis will be lost. So this should be extensive enough, even if it is focal and segmental,
Okay.
that it should lead to nephrotic syndrome,
Okay.
excessive proteinuria. Still, okay. So it means even from this there will be no leakage, but from here there will be excessive leakage. And those who are involved, they are actually taking their part, and the kidney is losing a lot of proteins. On electron microscope, there is typically podocyte injury to the podocytes. Then the membranous glomerulitis, it is 85% primary without any known cause, while the 15% it is secondary to SLE, secondary to infections like hepatitis B, malaria, syphilis, drugs, and some inorganic salts, typically penicillin. Those people who have got injection penicillin without sensitivity, they are usually ending up into membranous glomerulitis. Then people who have inorganic salts, for example, gold, or they inject mercury. Previously in some jails they used to inject mercury into the blood, which causes this severe renal failure, and ultimately a patient is having edema and a lot of problems. So there is no physical injury, but the patient is damaged from inside because of this. Malignancies, sometimes cancers, for example of lung and colon, they can also have glomerulitis, which is called membranous. Common age is 30 to 60 years, deposition of antigen antibody complexes. So this is the disease. Previously two were mainly related to antibodies deposition, but this one is typically because of complexes. So this is the difference between them. There is more than 60% of the time persistent proteinuria. So a proteinuria which is for many years, it is still present. And 40% of these patients, they go to renal failure. So ultimately, they are completely failed. And morphologically, there is diffuse thickening of the capillary walls, So you can see that all capillary walls, they are more thicker.
Thick.
So there is diffuse thickening, there is subepithelial deposits. So you can see this is the epithelium, which is podocytes, and below them there is typically an array of deposits. These black color things are the deposits of the antigen antibody complexes. And this is something which is called spike and loop pattern. What that means? Spike. What is the meaning of spike?
Spike.
Actually, you know, the deposits are here, and then the membrane is okay. Then there is deposits, membrane is okay. Then there is deposits, and the membrane become okay. So these areas, they look like spikes, and the other areas where there are deposits,
Dome.
they look like dooms. So dome and then the spike, dome and then the spike. So this is the typical morphology which we see on electron microscope of these areas, this spike and dome pattern. And on immunofluorescence, we see granules-like deposits. So you can see typically the granules-like deposits in all the glomerulus. So these are the membranous glomophytes. Then the second last is membranoproliferative. It can be idiopathic without any cause or secondary to chronic immune diseases. For example, people who have hepatitis C, hepatitis alpha-1 antitrypsin, HIV and other malignancies, they can present with membranoproliferative. What is morphology? The glomeruli here, they look like more lobular, as if there is one lobule, another lobule, another lobule. So the glomerulus have a loop-like lobules, lobular glomeruli. And the difference between membranous and membranoproliferative, that there is predominant mesangial proliferation. So here the mesangium in the center, that is typically very hypercellular. There is a lot of cellularity of the mesangial or mesangial damage is there. Leukocyte infiltration. Besides them, here and there, you will find some neutrophils, some multilobulated. You know what the neutrophil look like? Like a multilobulated nuclei.
Yes.
So
Yes.
they are typically seen in many places in this, in the glomeruli of membranoproliferative. And we typically see on PS positive a tram track. You know tram or train, which we are seeing here. So what is its pattern? That this is two lines which are going side by side and they have some connections. So when we go through electron microscope, we see that the glomerular basement membrane of this disease has a tram track like appearance. Okay? So this is the thing which is there, which you can use or check by a stain which is PAS, periodic acid shift stain. And type 1 type of membranoproliferative have typically subendothelial deposits. The deposits are just below the podocytes.
Like the
Deposits of antigen immune complexes. Okay? Right, so your test revealed that you are retaining fluids. Actually, even it is well clear, so they don't need any test that he has having excessive edema. So with this, we will just finish, but we will start with diabetic portion, which is called
So
diabetic.
SLE and systemic will be next.
Systemic.
Systemic we will inshallah tomorrow. Not tomorrow, it is on I think Thursday. So we'll take it, okay? And then we will take the rest of nephritic with some renal changes.
Okay, sorry.